Hey guys, so there was a question about nifedipine. So we really are focusing, we're not having preterm labor on this test, but I do want to talk to you real quick about mag sulfate for preeclampsia. So we do use nifedipine for preeclampsia, for blood pressure control. We usually do that when they're very early and they're not really a big candidate for mag sulfate yet. Let's say that they come in, they qualify for a preeclampsia diagnosis. Let's say their blood pressures are 140/90 on 2 separate occasions. Let's say with proteinuria in this particular case. So we're like, okay, they're preeclamptic. Well, let's say they're dilated 4 centimeters and she's contracting. So we don't feel the need to start her on mag sulfate because we think she'll deliver before she's through this period. So sometimes we'll start them on nifedipine for the pressures. It just decreases the pressure. But on the other hand, so mag sulfate we use for preeclampsia, especially if it's severe. Whenever we have pressures of 160/110, or we have 140/90 on 2 separate occasions with all of those ominous organ system involvement, we start to really worry that this person could be on their way to a seizure or on their way to HELLP syndrome. So we use mag sulfate really to prevent a seizure. That's the most common reason we use it. It's a very, very dangerous drug. It has to be on the pump. So we just give them mag sulfate, increase their level. It relaxes the smooth muscle in the CNS. It can relax the CNS so much that it can cause them to go into a coma. So therefore, we must look at their orientation. Are they ANO ×4, person, place, time, and situation? Do they have DTRs? You want to make sure that, remember, DTRs, deep tendon reflexes, are a sign of central nervous system irritation. +4 is not good. It tells you that they're super irritated. However, we don't want to give them too much magnesium sulfate to where they have no DTRs. That tells us that we could be toxic. And then, of course, we monitor for clonus because that's a secondary reflex that comes in the presence of a really irritated CNS. And so we would like to see that go away. So with mag sulfate, you guys, we do use this for preterm labor. It is a smooth muscle relaxant. So as a side effect, it relaxes the smooth muscle, and your vascular walls are made of smooth muscle. And so it relaxes the vessels, therefore the blood pressure goes down. Also, your uterus is a smooth muscle, and so it will cause the contractions to decrease. That gives us enough time to give the betamethasone, which is our dexamethasone or any glucocorticoid that we're going to give to the baby to help mature the lungs. And we talked about this before. It takes 24 hours for that to get into the baby's system. So mag sulfate also protects the baby's brain from cerebral palsy. And so we know it's a great neuroprotectant. So anybody under 32 weeks, we normally give them mag sulfate in preterm labor. Also, you need to monitor the baby, the fetal heart tones, when you're giving mag sulfate because it can lower mom's blood pressure, lower the pressure to the placenta, and therefore it could cause uteroplacental insufficiency. That's why we have continuous fetal monitoring. Also, we need to have a Foley catheter in when you're giving mag sulfate to make sure that urine is coming out at least 30 cc's an hour. Also, check the respirations because your lungs are made of smooth muscle and we don't want them to stop breathing. And then remember that the reversal agent is calcium gluconate. Thank you.